Hello, this is just going to be a short slideshow on respiratory A and P. We'll go over a few things like the structures of the upper airway, the anatomy of the lower airway. Most of the presentation is going to be the physiology of breathing. We're going to talk about lung volumes, and we're going to finish it off with some oxyhemoglobin dissociation curve stuff. And I like to throw a little bit of microcirculation at the end of that. We'll begin this way at the top then for the upper airways. Think about this. What is the role of the upper airway? We talked about three different responsibilities that the upper airway has. And that would be the upper airway has to warm, humidify, and clean the air as it goes through the nasal turbinates there to make sure that the air is nice and clean by the time the air gets down into the trachea here. So this all right here, this is called the nasal turbinates. A lot of body surface area there, so we can do that, warm, humidify, and clean the air. The next thing that we have to think about is if that isn't happening, if air is going through the upper airway too fast, the epiglottis will try to cover, the epiglottis here, will try to cover the trachea to protect it from what could be dirty or too cold, too dry of air. This bone here is called the hyoid bone. And the hyoid bone is a free-floating bone. It really isn't connected like the way we usually think of ligaments. There is some connective tissue here where it's attached in some way to the base of the epiglottis. This gives us some ability to manipulate the epiglottis. When we move the mandible anteriorly, when we move it this way, we can manipulate this and keep it out of our way. One of the problems that we have with ventilation is if we ventilate too fast, which sometimes happens when providers can get a little excited, the epiglottis will cover the trachea because the air is moving too fast. By doing this, we might be able to manipulate that a little bit. Here is the, this is the trachea behind it. So this is the thyroid cartilage and maybe a prominent Adam's apple in some people. And the next structure here is not really well displayed, but this is cartilage, right? So up here we have cartilage, here's cartilage, kind of the cartilage U shapes that protect our trachea. So what I'm trying to get to here is this area here is the only ring that goes around the trachea for the airway. So this is the cricoid ring, and this is where we would push then for Selleck's maneuver. From here, pushing it down like that. So we go to the lower airway, not much that we need to know here. We need to know the two pleural linings, get familiar with that medical terminology that we use when we're talking about the lining of a cavity and the lining of the guts pretty much. Your viscera pleura is going to line your lungs, and your parietal pleura will be like saran wrap lining on the inside of your chest. And then in between there, we'll have pleural fluid that will give us a frictionless environment. The carina here is where we split. Not the best medical and what would you say, anatomical picture here. The right side does less of a big turn, all right? So it's easy for us to put the endotracheal tube. If we're going too deep, we'll go on this side. So this is the carina, and the other thing from this picture that we need to know is this is the diaphragm, the big muscle of respiration that is mostly responsible for that big negative pressure that draws air into the lung field. And as we go down the lungs, from the bronchus to bronchi, bronchioles at the end, I need you to know the anatomy of the bronchioles. smooth muscle, no cartilaginous rings here. So sometimes it looks like there might be cartilaginous rings in some anatomical pictures, but those aren't complete rings. So that allows for the the bronchioles to completely collapse. In some areas in the bronchioles, we have a little bit of cilia trying to move stuff up into the area where we can cough it out. These bronchioles have to have cilia and surfactant. The surfactant helps us keep things from sticking together, and the cilia helps move stuff back up into the upper airways so we can cough it out. And lastly, kind of what we see this picture as is a picture of the alveoli, and I want you to just kind of realize that this area where we're kind of seeing a capillary bed there, that area really has to be thin membranes, very thin, almost hard to wrap your mind around that. We have to have that free floating of the gases, CO2, to come back into the alveoli and oxygen to go into these vessels. We can't have a lot of fluid in between there. We can't have thick cell membranes there. It has to allow for an easy egress and movement of the gases. So that's why CPAP can be so important or effective. If we start messing with the pressures, we're going to push fluid one way or the other. It's the same thing when we're talking about pathology. It's so easy to kind of understand that when the left side of the heart's not working, we build up a little bit of pressure and we are going to have fluid moving from the vessel into the path of least resistance, which will be the alveoli. So that's about enough for physiology. Let's talk about some that was not patho, that was anatomy. Let's talk about physiology. So here, we're going to talk about the regulation of ventilation, and we learned this as an EMT a little bit. It has to do with a hypoxic drive. That's where we would have learned it as EMTs. Here, we should realize that our respiratory rate, the normal respiratory rate of 12 to 20, that's where we are when, we'll be at 12 when we just don't need oxygen that much. I would say that we breathe actually slower than 12 when we're just sitting in class and we have good posture. And we probably breathe more like 14 or so with bad posture, and maybe we're excited about something. So our respiratory rate and depth changes with what the needs of the body are. We see that really evidently in a hypothermic patient where they don't have to breathe so much, so they don't. And they breathe shallow also. So here we talk about the regulation of that. How does that work? First, the primary is the pH of the cerebrospinal fluid. And what we're going to more directly talk about is the CO2 in the blood, because we're also going to talk about oxygen in the blood, because we're going to talk about hypoxic drive. I think as paramedic students, we can focus on the idea that we have chemoreceptors in the carotid bodies. Of course, that's in the carotids, constantly measuring CO2, and we'll make adjustments when we need to make adjustments. And there's just a constant feedback mechanism in there between the brain and we'll have to include the lungs there, and then how the composition of the blood is doing, and that adjusts our rate. Again, I don't want to belittle too much. The primary regulation is the pH of the cerebrospinal fluid. And so those chemoreceptors send a message to the medulla. All right, the medulla has the primary responsibility for respirations. All right, and of course the medulla oblongata is located in the brainstem, along with the pons. And the pons has two kind of, I like to call them backup or assistant centers. And we have the apneustic center there. That I like to say, to begin with, that apneustic center prevents apnea. It has an excitatory role with helping the medulla stay on task pretty much. And the pneumotaxic center has everything to do with that Herring-Brewer's reflex. That is the point where we inhibit respirations. So with this next picture here, we have the medulla there, the brain right up on the top there, the dorsal respiratory group. And again, when we first talked about this, I minimized the talk of the dorsal respiratory group. This is where we have that primary center for respiration, all right? So this is what is going to initiate, boom, respirations. And when I usually talk about this, I'll say that it's a constant flow of a neural signal saying, let's breathe in, breathe in, breathe in, breathe in, or, the actual word would be contract, right? Contract, contract, contract. And it's saying that to the diaphragm and the intercostal muscles. The ventral respiratory group just kicks in when we're in distress. And so that's going to be kind of responsible for the accessory muscles that we talk about, the other muscles in the intercostals and the muscles of the back and such, where we'll have an increased inhalation and exhalation. And then up here is in the pons now, we have the apneustic center, which is going to promote respiration. It's going to stimulate prolonged inspiration. That's another thing that it might be responsible for. When we have a pontine problem with the brain stem, usually we're talking about head injuries there. Part of the apneustic respirations will have that prolonged inspiration. And then the pneumotaxic. If we break that term down, pneumo is going to be lungs, and taxic is kind of balance. Ataxia is imbalanced. So here, pneumotaxic is a balanced respiration. So here, as I was saying before, where the dorsal group sent message down saying contract, 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 then we have stretch receptors in the lungs that basically says we're contracted enough. We have a full inspiration. Sends a message up to the pneumotaxic center, and then the pneumotaxic center inhibits respirations. And that causes us to have nice, smooth respirations in and out. That whole thing is called the Herring-Brewer's reflex. So inhalation is an active process. Active, we're using our muscles, we're using our nervous system. Something that we can also maybe attribute with that right away is when we're breathing in using muscle, our airways are bigger. All right, the negative pressure causes those airways to be bigger. On exhalation, it's passive. It should be just passive, the absence of a nervous system. All right, unless we're really short of breath and that ventral group kicks in, it should be passive. No muscle, no nervous system. It's just the absence of those allows for exhalation. And when we're exhaling and we have lower pressures, those airways will be just a little bit smaller than when they were on inhalation. For lung volumes, this is just like quiz questions, maybe even test questions. We're going to even dive deeper into lung volumes and capacities when we're in medical emergencies 1. But here, I just want you to remember a few things. The tidal volume for the average tidal volume for a 175-pound male patient, college age, is about 500 milliliters. If we do the math on those, this math becomes more important, I would think, when we start talking about peds. But an adult tidal volume is 5 to 7, and the infant tidal volume is 6 to 8 milliliters per kilogram. So 500 is just a term that we often use just to make things simple. All right, the tidal volume is around 500. Of that 500, about 350 of it will get to the alveoli, and that's called the alveolar volume. And then that 150 that would be left, that's your dead airspace. All right, the dead airspace is going to be about 150. So our lungs have a capacity for like 6 liters, and we move 500 around at a time. Only 350 of that gets actually down to the alveoli. And then we just have a little bit here. Minute volume is going to be the amount of air that we move in, and we're going to multiply that by the respiratory rate. And then the alveolar minute volume is what we get all the way down to the alveoli. For us as paramedics, it's just a matter of talking about that. It's not something we actually measure. And so what is in the air that we breathe? I think about that for a second. What is it that we breathe when we're breathing normal air? And here's the answer. Most of it is nitrogen, 78% nitrogen, 21% oxygen, and then some other gases, all less than 1%. That pressure, when we're at sea level, then the pressure is 760 torr. And that 760 torr, if you wanted to make that a measurement, you might see it as millimeters of mercury. All right. So millimeters of mercury. A lot of other times when we're talking about respiratory, we'll talk about centimeters of water pressure. But this is millimeters of mercury, same thing as what we use when we're doing blood pressures. And so 21% of 760 is 159 torr. Sometimes you'll see that written as 160 torr. So this is just a little bit of information to help with maybe this slide here. We're going to kind of concentrate on the right side of the slide to begin with here, and this is the obvious lungs at the very top. I don't mind talking now about this area right here, which exists, right? We have capillary bed here and the lungs here. Remember, this is like the neighborhood then that we have a problem with when we're in ARDS. At the very beginning of CHF, this is where edema would be. Like, I should say maybe at pulmonary edema. This is where the edema would be, in between. Not giving us a change in lung sounds at all. Its edema would be here. And then as the water crosses all the way to the lungs, now we have the pulmonary edema that we can hear. So the beginning here is, as we were talking about, atmospheric air has, which is 20%, 21% oxygen, has 159 torr. The pressure of oxygen in there is 159. By the time it gets down to the lungs, we have 100 torr and 40 torr of CO2. And that's just the idea of we're just moving 500 at a time, going in and out of a 6-liter field that it can go through. All right, so by the time it gets to the alveoli, we no longer have that 159 torr. And then when we breathe out, we might have remembered from CPR classes, we breathe out 16% oxygen. So we're going to lose, I guess you would say, 120 torr there. And our CO2, as we're breathing it out here, is around 27 torr, which kind of doesn't jive with what we usually think of as capnography. A lot of times we would say, oh no, that's wrong. That should be 40, give or take. But when we're measuring capnography, we really are measuring where the alveolar air. And so that's why that 40 goes, it's at the very top of the capnography wave. That's where we're getting that 40 torr. All right, so, and that's the normal is 35 to 45. So we had 100 torr now in the artery. The pulmonary vein, this would be the same if these values would be the same value as here, right? Because our pulmonary vein is the same as our systemic artery. That's the arterial blood that we think of, the oxygenated blood. That's going to go down to tissue. And again, all of this, I think it's probably time to say, all of this, the movement of gases, is all just about diffusion. It's not osmosis. That would be the water. It's not active transport or active diffusion. It's not facilitated. It's none of those. It is simple diffusion. The air is going to move from an area of I should say that air particles, maybe, the gases will move from an area of high concentration to low concentration. So down here, oxygen is going to go into the tissue and CO2 is going to come out of the tissue, get back into the venule side here. And on the vein side, we'll have an O2 of about 40 torr and the CO2 of 46. As we come up to the pulmonary artery, this will be the same. And as long as we have a good, what would you say, diffusal surface here, we should be able to exchange that and we come out with this alveolar air, which is exhaled again. So over here, that's just about the gases, and just having the gases in our bloodstream isn't good enough to keep us alive. We need to have hemoglobin. The hemoglobin has to have sites where iron is very important. Each hemoglobin has 4 receptor sites that's going to hold on to a piece of oxygen and bring it to the tissue where we need it to be. The just one more little bit of anatomy, maybe physiology term is this process of air moving out in and out here. This is called external respiration because external of our body. And then here, this is called internal respiration. Internal respiration is the movement of gases at the tissue level. And since we have hemoglobin, when we make this oxyhemoglobin dissociation curve, it has like an S shape here. And here, what we want to know is if hemoglobin was always attracted equally all of the time, 1 for 1, this line should be just a straight line going, I guess it'd be diagonal from the corner to the other corner. But it's not true that we have hemoglobin, and hemoglobin binds differently depending on the neighborhood that the hemoglobin is in. Where hemoglobin is in an environment where there's a lot of oxygen, there's a strong affinity for oxygen and hemoglobin, so the oxygen will jump on. When we get to an area where there's less oxygen, and something that's true about that is usually there's more CO2 in that area, then the hemoglobin loses that affinity and the oxygen jumps off. And that actually is what we want to have happen. And again, for this S-shaped curve, when one jumps off, 4 total will jump off. All right? So 2 big parts here. One is where the hemoglobin is in a neighborhood where there's a lot of oxygen, there's a strong affinity. Where there's a lot of oxygen, there's probably only a little bit of CO2 also, or less CO2. And the opposite is true also. When we get out to an area where there's low oxygen and high CO2, there will be less of an affinity and the hemoglobin will jump off. And one jumps off, 3 more will follow right after that. And when we talk about microcirculation, so we're really close to the end of the slideshow here, is the RBCs in central circulation, where there's a big old high oxygen concentration, they jump on. When they get out to the tissue, we want that oxygen affinity for hemoglobin to be lower. And we also want that to happen in an area where there is a need for oxygen. So what happens at this microcirculation, when we go out to the periphery, this is the other term that you need to know, big, quiz question, test question. When we have a lot of CO2 building up in an area, you might say, why would CO2 build up in an area? Well, CO2 is just a product of metabolism. So when CO2 builds up, we will get vasodilation. We get vasodilation. Another thing, remember, if we're talking about the capillaries, we're talking about arterial sphincter opening, a precapillary sphincter opening. The blood will go through that area where there was a higher amount of CO2, which also should be true is there'll be a low amount of oxygen. So now blood is going where we want it to. When it gets to where we want it to be, there'll be a low amount of oxygen there. There'll be less of an affinity between oxygen and hemoglobin, so the oxygen jumps off where we need it. So we vasodilate with lots of CO2, and then we vasoconstrict where the CO2 is taken away. So we vasoconstrict again, wait for it to build up, we'll vasodilate, and here comes the blood with the oxygen to fix that area. So that leaves us with this oxyhemoglobin dissociation curve that has some pathology, and this kind of describes some physiology. So here we're going to talk about a rightward shift of the oxyhemoglobin dissociation curve. Let's pay attention to the arrows going up. When in our body we have increased hydrogen, and remember, increased hydrogen is going to be a decreased pH. We have increased CO2 and increased temperature. We'll have a decreased affinity for oxygen. That's the hemoglobin, right? So they won't want to, be attached to each other as much as they usually do. That's where the rightward shift. And this is like, now we're talking about pathophysiology, but remember, for physiology, where there is an increased CO2, we get vasodilation, and the blood goes into there, and then we want that area to have less of an affinity, right? So we want that physiologically, like we want it to happen every day while we're sitting in class. We want oxygen to go to places where there's a need for oxygen. We'll have vasodilation there, so the blood is going into that area, and then there to be less of an affinity, so the oxygen actually jumps off, and we use the oxygen at the tissue level. The opposite would be true also. So for this left-sided, the pH goes up. Again, hydrogen went down. CO2 goes down. Hyperventilation is usually what we're talking about there. Or hypothermia. Now we'll have an increased affinity, which might sound good, but since decreased affinity might have sounded bad, but if it has an increased affinity, then oxygen is just going to stay on the hemoglobin. It'll stay on the hemoglobin, not jump off where it's supposed to jump off and go right back up to the central circulation. So the tissue would still be robbed of oxygen. So we can't have that either. And so you might see questions like, what causes a rightward shift? And what does a rightward shift mean to us as far as the hemoglobin's affinity for oxygen? And that's the end of the presentation. Feel free to take notes and make sure you know this content. Important for quizzes and tests. Thanks.